a sponsored talk by them. So, I'm Dr. Mayur Agarwal, DM DNB Endocrinology from Bhopal. So, we are here to talk about homocysteine and its clinical implication. To make the talk interesting, I'll be very brief and let us be very practical. How many of you have got homocysteine in your patient? Quite a few. Great. So, let's talk about firstly back to basic, that is biochemistry. That's more important. So it's basically it's an amino acid which is not used in making protein, but it's a one carbon donor. Okay, so methylation demethylation is where this homocysteine actually plays role. So if I can enlarge this would be better. Yeah. So if you see here, methionine is what we get from the diet, which is converted to homocysteine, and this is via SAM, that is S-adenosine methionine, which converts this here, and this is methionine transferase on which it acts, and then this happens, and this is cystathione synthetase, cysteine synthetase, where this deficiency is there. Then you have homocysteine urea. That's another disease, genetic disorder, and this homocysteine is converted back to methionine via this tetrahydrofolate to tetrahydrofolate. 5-methyl is transferred from this to this. That is what happens. So if you don't remember any of those things, just three things is most important. Firstly is folate, from where you have this tetrahydrofolate. So there are few disorder where you have more of the consumption, where this cycle get distorted and this gets accumulated. Then you have disorder in these enzyme where this get distorted. Again there is, and then you see here that DNA gets methylated via this methyl transferase, DNA methylation. This happens also here. So that's why many of the disorder happens when you have this cycle defect. Okay, so this you can consider as a whole. So three things are important: B6, folate, B12. Okay, so these are coenzymes which is required for this cycle to run in. Okay, so the normal value is usually somewhere between 5 to 10, and above 15 is what you considered as higher. But again there are various cutoff. In general we do not evaluate much up till 30. That is what happens. Usually it's something like prolactin, where the normal values are like 20 nanogram per ml, but usually up to 30 also you do get sometimes, and 100 is like tremendously high where you suspect prolactinomas. Severely, when you have so high values, you must expect something is not okay here. Those causes are different. Now let's talk about pathophysiology. What happens if this homocysteine gets accumulated? So there's increase in reactive oxygen species, and as I have told you, the role is there in DNA methylation. So there's defect in that, and hypomethylation of the DNA happens. The oxidative stress increases, and endothelial dysfunction happens. And because of this endothelial dysfunction, actually you have various other disorders, including all those atherosclerosis, dementia, stroke. What happens in diabetes? Almost like that. The reactive oxygen species increases. It's an inflammatory milieu which happens due to this. So even having this cofactor deficiency can lead to increase in homocysteine, can lead to increase in reactive oxygen species, can lead to increased risk of atherosclerosis and vascular dementia. And then the causes, firstly is the CRD or the CRF, whatever you call it. So chronic renal failure is where your homocysteine does not get excreted, and thereby you will have increase in homocysteine. Then hypothyroidism can also lead to this. Reason being, it acts on the renal thing. The renal flow decreases in hypothyroidism. Secondly, the hypothyroidism, people can have other autoimmune condition. You should be looking at pernicious anemia, which will lead to B12 deficiency, which will lead to this. And then people who are having hypothyroidism, they can have other malabsorption, they can have celiac disease. All those things can happen. Then anemia, B12, I have already told you, B12 is a cofactor which will happen there. Then all those metformin, cholestyramine, this niacin. Niacin basically it's takes the cycle away. The niacin also requires a factor which goes there. That is why this happens, that the niacin takes it more. That is why that methyl cycle stops here and increases at that site, whereas metformin actually decreases the B12 absorption. That is why you have more of homocysteine deposition. And then OCP is slightly controversial. In fact, the estrogen actually improves, but at that dose it may increase. So that is what is documentation is there. And I have already told you it affects the cardiovascular system, including the atherosclerosis, heart disease, strokes, the nervous system, epilepsy, dementia, Alzheimer's, all those things happen. And in fact, we are here at the Menopause Society, so we would be talking about the menopause, sexual dysfunction, pregnancy, infertility, all those things we would be talking about. And then the endocrine system, because it's an inflammatory milieu, diabetes do increase with this. It's a common thing. Osteoporosis do increase with this. That's common thing. Okay. If you talk about epidemiology, almost whatever test you get, it's like B12, vitamin D is deficient. And most of the people, whenever you talk to them, they'll say कि भाई हम तो धूप में बैठते हैं. All those things happen in clinical practice. But if you talk about the guidelines, they recommend that 15 minutes of exposure, that should be without clothes. Nobody is going to do that. So even sitting in sunlight will not make your vitamin D, and that is when it is already sufficient in those people. Those patients who are deficient will not have enough of vitamin D. They will require treatment. So all those vitamin D deficiency, B12 deficiency, folic acid deficiency, all those happens, and it's very common. You can see the prevalence. We are not going into details. All those 40, 50, 70% are there. Okay. Now, if you talk about gender, here you will see that rather than women, men are the one person who had more of this homocysteine. And if you adjust for height, if you adjust for lean body mass, if you adjust for EGFR, if you adjust for albumin we are adjusting because most of the this homocysteine is actually bound to albumin. That is why we are adjusting it. So all those, even after that also it is higher in men as against to women. And then difference is even up to the tune of 55 to 82%. Okay. And then with the age also there is increase in this, and especially in the woman you can see, because I've already told you when I was talking about the OCP, at lower level of estrogen this is more of protective, at very high level it is actually detrimental. So once the patient have postmenopausal woman, they lose that estrogen regulation, so the rise of this homocysteine is higher. That is what happens. Okay. Now let's talk about in the woman health. That's my talk today. So if you see, infertility is associated with this. Now how this happens? So basically it's the oocyte quality which is hampered with this hyperhomocysteinemia. If you, everybody of you would be knowing all those primordial, primary, secondary, all those follicle, all those development actually decreases when you have higher homocysteine level. Similarly, for a good this pregnancy, implantation is equally important, not just the ovum. So that implantation you require a good endometrium, and here you can see the endothelial dysfunction because of those reactive oxygen species. There is decreased nitric oxide release, and those flow, that vessel formation, all those oxygen delivery, all those nutrient supply, that is not there, and that is why the implantation is defective. Okay. And that is why this infertility happens. And not just, if you see here, this methylation, the DNA methylation part, that is very important for gametogenesis. Now when you talk about gametogenesis, it's not just the ovary, it is the sperm also, right? So both the sperm and the oocyte quality gets dropped in this hyperhomocysteinemia. Okay. And even a moderate level increase can lead to infertility, can affect the fertility of the patient. Now if you see here, folic acid, everybody of us are prescribing them in all those preconception period. So there is data that this decreases the rate of miscarriages, and this also have effect on the homocysteine level. I have already told you the tetrahydrofolate cycle, which runs along with this methionine to this cycle, homocysteine cycle. So folic acid, B12, B6, all those are really important. And if you see those patients who are treated with this, though the number is very small, 22, here there was decrease in the homocysteine level. Only 60 patients were included in this trial. Now let's talk about the PCOS. So here what they have done is they have taken the PCOS only in both the group, and what they have seen that those patients who had higher homocysteine level versus lower one, there was association with the BMI, estrogen level, and more derangement in the LH to FSH ratio. That is, both the groups are PCOS only, but one had a higher homocysteine versus the other having normal homocysteine level. So maybe there is a relation, or maybe it's an effect that they had more of BMI, that is why that's there. It's not the causation, it's the association which is shown in this study. Okay. And then similar study we had from India also, the left lower box you can see here, that was an retrospective analysis. This was recently published 5 years back only. So this is a retrospective data from eastern India, where it was shown that PCOS with hyperhomocysteine had higher risk of miscarriages versus those PCOS only with normal homocysteine level. So 70 against 29% was shown. And then even for the IVF ICSI, there is negative correlation of higher level of homocysteine with the oocyte retrieval. The pathophysiology remains the same, which I have already which I have already dealt with earlier, and this leads to poor outcome. Then recurrent pregnancy loss. This is a meta-analysis, and almost 50% of the recurrent pregnancy loss are unexplained, and there may be a role of homocysteine in this, as this is a risk factor for miscarriages, and it affects the fibrinolytic enzyme which play a role in pregnancy. Now this is regarding the PIH. Again, it's a prospective study, and here you can see more than 200 patients were screened, and there was association of higher homocysteine level more than 8 millimole, where the patient had more of eclampsia that was seen with the higher level. Again, it's a more of an association, I would say, rather than actually the cause. Okay, so this test may help you to screen for higher risk group. That is what is we meant here. And then same way you can see this study also showed the same thing for the preeclampsia thing. Okay. Then this is regarding the polymorphism, the MTHFR gene mutation that is there. Then more chances of osteoporosis are there. The reason remains the same. More of inflammatory milieu is there. It's a chronic disorder, chronic inflammation is there, which leads to more osteoporosis. It affects the heart, it affects the bones. That is what happens. And we have already talked about the cardiovascular effect. There is increased risk of atherogenosis, atherogenetic profile increases, the prothrombotic risk factors increases, and even an increase of 5 millimole per liter of this homocysteine increases the risk by 20% add on to the traditional risk factor, all those obesity, dyslipidemia, hypertension, all those. Beyond that, the risk increases with this also. So treatment is very simple for most of the patient I am talking about. For most of the patient, if you supplement with the cofactors, probably the patient will do good. If the levels are more than 10, you should be initiating treatment. I have already told you 15 is what is okay, but beyond 10 you can give this. The guideline do recommend to start with a lower dose, but in clinical practice usually we do give a full dose because there are no side effects. These are cofactors, these are multivitamin, nothing like overdose of B12 or B6 or folic acid can happen. If even if you overtreat, they are just going in urine, that's it, nothing is going to happen. So the guideline recommends to start with a lower dose and again reassess, and then if the patient is having higher homocysteine level, again to give a higher dose. In clinical practice, usually we start with a higher dose, that is what we do, and then we do check. And then active form of vitamin D are the thing we do give, and they may be more readily available for the body. So for folic acid, we have this tetrahydrofolate. For B6, we have pyridoxal 5-phosphate. For cyanocobalamin B12, we have methylcobalamin. But again, this is not too data driven, but that is what we do. And then there is effect of vitamin D on the mother and fetus, and you name the disease, whether you talk about any respiratory disease, including infection, including COVID, whether you talk about the dermatology disease, whether you talk about the bone, whether you talk about even diabetes, whether you talk about fertility, you name the disease, you will have some of the study associated with vitamin D. Maybe it's not the causation, but association, definitely you will have some papers on it. And in this COVID era, everybody took vitamin C, vitamin D, thinking that it may help, at least it will not worsen, it's not detrimental. But here a caveat is, do not overdose. Every day we find patient getting injectable vitamin D having higher calcium. That is what I see. I'm in DM endocrinology, so I see those patients with hypercalcemia. Those patients are referred, and many of them are actually over treated with vitamin D. They take, say, weekly pills for 3 months, 6 months, and then they come with hypercalcemia. So we have seen patient having vitamin D of thousands, 1100, 1700. Those patients do come to us. So do not overtreat here, like I told for the earlier one, that nothing is going to happen even if you overtreat, but here something will happen. And then there is role of vitamin D with the regulation of cytokine pathway, all those T helper cells, and the regulations of other hormone. It's an steroid hormone basically. Vitamin D is a steroid. Okay, so that is what happens. Now let us go. And then preconceptional supplementation, those are the things you would be knowing better than me, but there are studies that this folate, B1, B6, B12, vitamin D in preconceptional era may help, preconception time may help the patient. Now let's talk about the calcium supplementation. Again, there is role of calcium supplementation. It acts, it controls the inflammation, it controls the, it increases the antioxidant milieu in the body, and this may also help in the pregnancy. So the solution is, even in asymptomatic hyperhomocysteinemia, there is evidence that giving just the supplement of, say, folic acid, pyridoxine, and your B12 will decrease it. Individually, you can see here pyridoxine decreases by 22%, folic acid by 22%, B12 by 11%, all those. And if you combine this, this would decrease by some 38%. Even a small dose is good enough, but usually in clinical practice we supplement with a full dose. In summary, this is another important risk factor which you should be looking at, other than your obvious cause, which you do evaluate. Obviously, in all those, infertility comes to gynae first. So this is one of the things which often get missed. Though we have some data, may not be that important, but you should be looking at this. The treatment is very cheap and easy. That is again very important. And not only about the pregnancy, you are actually converting the inflammatory milieu and preventing from other diseases as well. And then nutritional deficiency in India is very, very common. We see left and right, and this supplementation is cheap, easy, and we can give them. So thank you for patient hearing. This is Dr. Mayur Agarwal, and we have this Hormone India clinic chain. We have started 12 centers in 6 states of India. The main center is here in Bhopal.
Thank you, Dr. Agarwal, for a
Yeah,
nice presentation on the homocysteine level and women health.
Yeah, we have recently started a complete diabetes and endocrine center in 7,000 square foot at Sai Board, where all the facilities are being provided. No, I have started it. I have given franchisee. Sure. Yes, very good question. See, injectable vitamin D usually should not be given. That is our orthopedics friend giving too much of them. Actually, when you do this, you are surpassing the physiological barriers. Body is much smarter than you. Let it maintain what it wants. When you give injectable, you actually surpass everything. The absorption rate, everything changes. Usually people don't require injectable. It is something like, say, chronic pancreatitis, where you have malabsorption, where you don't have secretions, where you have fat malabsorption. There is role of injectable vitamin D. Otherwise, giving oral is good enough. Another injectable indication is when you have hypocalcemia, where you give a rocatrol thing, calcitriol, active calcitriol, and then you may give injectable vitamin D. Otherwise, you don't require it usually. No, there are not much data, including for metformin also. These are very low grade studies. So we are not till there. And in fact, I heard your talk on the gut microbiome. All those are very research oriented. We don't have anything very stable about this, that okay, this should be done. It's not guideline now. Before I end, we have initiated few things here right in Bhopal, like the preventive podiatry we have brought for the first time, where the patient gets a complete uh, making of the this podiatry thing. We have machines for checking the pressures. Accordingly, the cast is being made, and the shoes are directly made from the factory. Then we have initiated obesity clinic for the first time here in Bhopal, where we do the body composition. We have apps for calculation of their carb protein. We do every visit there, whether they are losing lean body mass, hand grip strength. Weekly cloud based recall of the diet is taken. All those food logging is being done. In fact, we have initiated all those artificial pancreas 780G, all those, and then the adult vaccination drive for the diabetic patient, all those things, CGM, all those. Now we have a complete team which actually goes and connect to the patient every third day, and they see what the patient is eating, how much their sugars are going up and down, all those, because this sort of is treatment is required, especially for the GDM patient, for those who are on 4 times insulin, because they don't understand what to do. So they require an hand holding, and obviously none of the doctor can do it. We require a supportive team to do it. No doctor is so free to do it. No, it's a web based also. Yeah, yeah, yeah. Now everything is cloud based. In fact, the latest CGM which are launched here is sensor enabled, the CGM generation 2. They'll give you alarms when the sugars are going low, when the sugars are going high, what they are eating. Whenever the patient puts what he eats, at the same time, in real time, we are also able to see. But obviously, we cannot equip everybody कि भाई वो बैठ के देखता रहे कि क्या क्या खा रहा है. It's not possible. It's not practical. But every third day, yes, we do make a call. No, no, we have initiated too many things. We have initiated fellowship, observership. We have a complete CLIA-based in-house lab. We delivered within 2 hours the all the hormonal assays, and then we have guideline-based like a dental checkup. We have initiated. All the diabetic patients get a free dental checkup. High-end AI fundus camera we do have, and then we have also now tied up with the biggest body, that is RSSDI. We are starting post-MD fellowship. So this center we have started just 3 months back. I am into Bhopal for past 3 years now. Thank you. Thank you for patiently.